I'll take silence as acceptance. So thank you very much. Good morning or good afternoon, everybody. My name is Chris Bruni. I'm the Vice President of Sales at Security Health Plan. And we are very pleased to again be here on a webinar Wednesday with you. So thank you very much for tuning in. We have two wonderful guests today that are going to talk about, how the clinic has responded and the whole healthcare system has responded during this pandemic, and from just a couple of different angles. So I will go ahead and give them the introductions. But before we do that, I just want to remind everybody that the presentation will be sent out to you after it is complete. Ashley will get that out to you for anybody that has pre-registered, and look for that probably sometime later today, but otherwise early tomorrow morning. There is a Q&A feature up in the upper right-hand portion of your screen. So if you do have questions, feel free to just drop them in there for us today. We will read those out loud for our presenters and get a response to you today. If there are questions that we can't get to today, we will definitely get those out to the entire audience after the presentation ends, either later today or certainly before the end of the week. Couple of other things, just the housekeeping kind of items. You will be on mute, but again, just use that chat feature. And if there's anything else that you need, there is a survey that we send out after this. Please respond to that. We want to make these presentations about what you want to hear about. So please tell us in that survey, and we will be glad to build those into future presentations. All right, with that said, I'm going to go ahead and introduce both Dr. Krieger and Chris Meyer at this point. So Corey Krieger is Chief Quality Officer at Marshfield Clinic Health Systems. He's also the Director of IQIPS, which is the Institute for Quality Innovation and Patient Safety. Dr. Krieger has his medical background from the University of Wisconsin, so a UW grad like I am, although you've got seriously more education than I've had from the institution. So very pleased to have him. He joined Marshfield Clinic back in 2003, specializes in internal medicine and pediatrics. And let's see, what else can I tell everybody about you? Let's see. Oh, you also oversee the ACO, which I think is just kind of embedded within the Chief Quality Officer requirements. Corey will be our first presenter today, and then he'll be handing the baton to Chris Meyer. And Chris is the Director of Virtual Care and Telehealth at Marshfield Clinic Health System. Been in that role for, I think, about 4 years, if I'm not mistaken, Chris. Previously, Chris was actually the politician in Marshfield. He was the mayor of Marshfield for about 10 years, a little over 10 years, I think it was. And then previous to that, served in an IT role at the UW here in at the Wood County location in Marshfield. So very pleased to have both of these guys joining us today. I've had the great pleasure of working with both of them on projects over the years. They won't admit it, but I will. So it's been my pleasure, not theirs. But I will now hand it over to you, Corey. Take it away.
All right. Well, thank you, Chris, and pleasure to be here today talking to the group. So we'll go ahead and get started, and brief agenda of what we'll cover today, which I won't go through in detail, but we'll start by taking a look at what Marshfield Clinic Health System did, rewinding the clock back to early 2020 when COVID first started to be on the radar screen for our geographic area of the nation, and then what's happened since, and at a somewhat high level, the preparations that have been taking place through the system, transitioning over into how that's impacted our care delivery processes, and specifically some of the new services we've been able to offer. So back in March, and actually it was a little earlier than that when we first started the meetings and the planning, but in March we formally mobilized what we call the Incident Command Structure. And ICS, for those of you that might have some military background, this might be familiar to you. It's really derived out of a military structure that was utilized to handle situations that require agile, rapid movement, planning, and mobilization. And so the healthcare industry has adopted that approach, and we've in fact used it here in Marshfield on several different occasions. In fact, several years ago, some of you might recall when we had the Ebola scare as a nation, we actually had instituted the incident command structure back then in terms of our pandemic preparedness. Now, of course, that never came to be at a national level, thankfully. That was a great opportunity for us to work with our hospital partners at the time. Now with the health system having more of a role in hospital operations, COVID's really helped us to continue to fine tune our ICS approach. One of the key issues with incident command is the agility and the need to make rapid decisions. And we've taken that to a level to really be inclusive of all the stakeholders in our system that have a role in care delivery. So I'll share with you in a moment what that command structure at a high level looks like, but it'll give you some sense of not only the complexity, but the inclusiveness of what we've done to try to make sure that we are accounting for all of the needs of our patients, partners, and healthcare system as we've laid out our plans. Our immediate goals were really to reduce the risk for our patients and visitors to the health complex, to make sure that we're ready for a surge of patients, whatever that might look like. And there were a lot of unknowns back in March. There are still certainly unknowns today, but I'll say back in March, nobody knew quite what to expect. So we were planning for a worst case scenario. We also wanted to make sure we were meeting the immediate healthcare needs of our patients during a time when there was a national and statewide shutdown. We were in a position like other healthcare organizations of recognizing that we are a critical service and we needed to make sure we're continuing to care for patients and that we're not causing harm to people by procrastinating on care that's needed today. So that was an important part. And then certainly supporting employers and other healthcare partners as we went through this. So critical in our incident command structure was our interactions with public health officials. We had our occupational health team with Dr. Cronrath involved to really talk about how we support employers and make sure that their workforces stay strong and healthy, as many of you are also viewed as critical services for the communities. And then the intermediate goals, which really looked at beyond kind of the May-June timeframe, how do we start to look toward restoration? How do we bring things back online in a new way where we continue to focus on that reduced risk of harm and start to ramp up on some of the needs of our patients that might have been put to the side during the period of shutdown. And then at the same time, in tandem, continue with our surge planning. And then finally, the long-term goals, which are really around how do we operate, post-COVID, whatever that looks like. And people argue, this could go on and for the next 6 months. I think it's more likely that we're going to be dealing with this not in a term of months, but for years to come. Even if we do get a vaccination, there's going to be some definite long-term impacts to how our society operates and certainly how the healthcare system operates. So what does the new normal look like, and how do we maintain that continuous state of readiness as we go forward? So this is not meant to be an eye chart, but it is just to show you at a high level what our incident command structure looks like in the health system. And what you'll see is we have our incident command dyad team, which is our chief medical officer and our chief operations and financial officer partnered together. And underneath them are 4 pillars as identified within the incident command structure. A pillar for operations, who I happen to be the chief of that section. A section around planning, and my dyad partner, Tammy Simon, is in charge of that. We have a HR piece, which is split into 2. So you'll have the people piece of things, and then the supply chain piece of things. So both of those delineated in yellow. And then there's a financial section as well. And so all of us worked together with our dyad leadership. We had support from our public information officers, our liaisons, and our safety officers. And we had several medical technical specialists from places like infection prevention and medical ethics. And the list goes on in terms of folks that would be pulled in to focus on how we handle scarce resource issues, or how we make sure our facilities are readied or altered to be able to care for the patients that might be coming in. And then in each of our regions across the system, we have a parallel incident command team regionally that funnels up through the system and is coordinated with the system to meet the needs that might be individualized to that area of the health system. So they have a similar type of a structure, same types of sections underneath, same types of subsections within that are handling the needs of those respective regions. One of the outputs that came from the preparation, and this is just a screenshot of the dashboard that was developed to help us with tracking, were tools that helped us get a better handle on where we are with regard to caring for our patients and what supplies or critical elements are needed as we're moving through the process of a surge, should that happen. And so the screenshot I have up on here happens to be around call volumes coming into our nurse line, and I'll talk about that a little bit more in a couple of minutes. But track how many calls are coming in, how many of those might be associated with concerns around COVID, how many of those patients are getting appointed into our system, how many patients are getting admitted to our hospitals. We also have, and I didn't take screenshots of all of these, but we also have a tab on here where we can look at supply chain, and we can know real time how many surgical masks do we have, how many N95s do we have, how many medications do we have of any given type that might be needed to care for our patients, and where are those located. We have, I talked a little bit about medications, a shortages tab that helps us look at those critical meds that are deemed necessary to care for the COVID patients. Those might be things like medications needed to sedate or paralyze a patient while they're on a ventilator. Again, how much of that do we have? How many patients can we handle? How do we move those medications around our system if they're not in the right place at the right time? Same thing for a variety of other different issues that we're tracking on this dashboard. So all of that information was utilized, and what we realized early on in the state shutdown, as we were ramping down our routine care delivery for patients, we said we needed to reduce our volumes, and the reason we needed to reduce them were the unknowns and not wanting to harm patients by bringing them in for services that weren't critical during a period of time where we couldn't necessarily assure that they wouldn't be put at risk of contracting COVID by coming into the healthcare system. So one was a patient safety issue, but the second really was that ability for us to start to develop the information I just shared with you and really develop our supply chain, start to build our capacities and plan appropriately for a surge that might be coming. And then also for us to re-examine policies around how do patients come into our facilities? How do we screen them? Are we allowing visitors into our facilities? And we decided to make some changes and like many other health systems, restricted the number of patients and visitors coming into the system. Again, fewer people, fewer interactions, lower risk. And then issues around masking of patients. We were an early adopter with masking to make sure that we're reducing the chances of spread of disease. And then also how patients physically move through our facilities. How do we maintain social distancing? And that created an opportunity for us to revamp waiting areas, change our check-in processes, and do other things that could reduce risk of interaction between patients. This slide really looks at what's happened as we've moved through the last few months and gone from that period of shutdown to now that intermediate period of moving back to focusing on wellness and chronic disease management, getting those patients that might have procrastinated or not wanted to come into the health system or couldn't come into the health system during the earlier COVID time period, to get them back in and make sure that we're not neglecting care that's needed. So I'm happy to report today that we're able to now see all of our patients. We've had a very positive response from the community in terms of patients being willing to come in for their routine care, which is great. We've received a lot of positive feedback from our patients in terms of their being appreciative of the screening process and some of the other changes that we put in place to help give them assurances around having a safe and productive visit with us while they're on campus. We also have been tracking and are being good stewards of resources. So we're not hoarding, but we're maintaining an ample supply of PPE and other necessary products such that we feel that we are in a good position that if we did have a surge of patients, we're up to the challenge of meeting that need. And then we identified some new opportunities as we move through this as well. And the graph that I share here really highlights, I think, how care has changed over the course of the last few months. And this graph really goes back to 2018. And what it looks at are the call volumes that we normally would experience on our nurse line. And so you'll see it does vary a little bit. Usually during the winter months, we will have a little bit of a bump in terms of volumes, and then that trails off into the summer months when virus season ends, and we tend to have a lower volume of calls. Back in 2019, we had a little bit of a bump during viral season, but not as much as 2018. It was a pretty light year in terms of the virus and how viral illness affected our population. But you'll see as we came into fiscal 20, we were kind of in that same boat, but then right around the time that COVID first started to kind of hit on the international scene, and virus season was upon us as well with influenza last year and some of the other respiratory viruses, we saw kind of our normal uptick, but then things never stopped. As we got into that March timeframe and all of a sudden the state shutdown happened, we saw a tremendous surge in our volumes. And that was frankly a real challenge for us to figure out how to staff a 24/7 nurse line to be able to meet the demands of our patients. And some of you may have personally experienced or heard family members, employees, or others that had been concerned about some of the potential delays that were experienced, because there were times where we were nearly 24 hours behind in being able to take phone calls real time, even with all hands on deck to answer the phone, because volumes were running at 400 to 500% of what we would normally see. Things did quiet down a little bit as we came into the period of March, April and May. And then as you are well aware, with COVID being on the rise again nationally right now, and certainly in the state of Wisconsin as well, we have seen an uptick in our volumes again, such that we are now at or cresting where we were back in March. But because of our planning and our flexibility and staffing, we've been able to get near real-time ability to answer those calls. So that's just one example. We've had to do some changes in other areas as well. So Care My Way is a great example. Some of you are familiar with that service to meet acute needs of patients by seeing them either over the internet or by telephone. That service has been available 7 days a week, from 7 in the morning to 9 o'clock at night. We have not seen as much of a surge in the Care My Way utilization. There's been some. But we have not needed to expand hours there at this point. The after hours requests by patients are almost zero in terms of care after 9 p.m. at night. So we have not had to flex staffing there yet, but we are prepared to do that should the need arise. And then we also have looked at our clinic office practices and started to identify some new opportunities that have availed themselves to us around telehealth. So with that, I'll transition over to Chris.
Thank you, Dr. Krieger. So as Dr. Krieger mentioned, one of the things that Marshfield Clinic did initially in our COVID response was initiate an instant command structure. And for me, that really started on March 13th, which was a Friday. And it was a call from Dr. Krieger who said that we're going to start closing our facilities to prevent the spread of COVID. and we need to virtually connect patients and providers. Now, telehealth isn't new to Marshfield Clinic. It's something we've done since 1997. We've offered the ability of patients and providers to connect with two-way video since 2017. But this is the first time we looked at doing this system-wide. And in the past, there had been significant reimbursement barriers, largely led by CMS or Medicare, that prevented the delivery of care wherever the patient wanted. Normally, that care has to be delivered in a clinical facility like a hospital or a clinic or a nursing home. Your canoe or your car seat at the McDonald's parking lot didn't qualify as an approved place of service. I asked Dr. Krieger how many providers we needed to onboard, and he paused for a second and then said, all of them. And so on Monday, we hit the ground running. All projects in Marshfield Clinic essentially came to a stop as there was a full effort to launch video visits for patients with all providers in our system. There were really two things that came together to make this possible. As I said, prior to COVID, there were reimbursement barriers that prevented the delivery of care through your iPhone unless you were paying cash for it and choosing to do that yourself. Insurance companies generally would not reimburse for that care. On January 31st, Secretary Azar announced the public health emergency, and on March 27th, the CARES Act was signed into law. And the CARES Act had been in negotiations for about 7 or 8 months at that point, so we knew what was going to be included in there, and it was accelerated to be passed quickly. One of the key pieces in there was the ability to reimburse for two-way audio and video visits, as well as for phone calls to patients who were unable to come into a facility because of COVID-19. Those two things together changed the reimbursement structure and allowed us to move to virtual delivery of healthcare for all of our patients across our system. Next slide, please. So from March 16th to the 25th, we launched virtual visits or telehealth at home for all 1,500 providers and clinicians in Marshfield Clinic. Shortly thereafter, the next week, once the CARES Act passed, we added phone care. So for patients who had access to internet problems, barriers, getting internet access, old technology, or just don't have it, they still can't come to the clinic either. So we needed a way to connect with them, and phone care was the way we did that. Next slide, please. So what did our volume look like? I should preface this by saying that last year, our telehealth program was responsible for connecting providers and patients located in different Marshfield Clinic facilities. So a patient in Minocqua, for example, could go to the Minocqua Center to see a dermatologist in Marshfield. That's what telehealth largely was prior to COVID. Last year, Marshfield Clinic did about 12,500 visits via telehealth, and we set a goal this year of 15,600 visits for telehealth. Of course, that was all planned pre-COVID. The chart you're looking at shows our volumes from the start, March 16th, where we had some visits that week initially, and ramped up over the next 4 weeks to the point where we were doing over 4,000 visits per week by mid-April. We peaked at the end of April and early May where we were doing over 6,000 weekly visits via telehealth. And then as the facilities opened up, the governor's safer at home order was overturned, many businesses opened back up, and Marshfield Clinic had a controlled reopening of their facilities. We saw patients start to come back to the office. This is something we're looking at and trying to understand better because these reimbursement flexibilities that have been made possible through the CARES Act and the public health emergency are also likely going to be made permanent. The president issued an executive order on August 3rd to that effect. Next slide, please. One of the things we very much focus on in Marshfield Clinic is patient satisfaction. What do patients think of the care they're getting from us? And like all of our other services, we did survey patients who had a telehealth at home or a phone care visit. We do a random sampling. I believe 20% of the patient visits per month get a survey. And at this point, we have around 500 completed surveys between the two services. We have a goal of achieving a top box score of 75% or better. That simply means that on a scale of 1 to 5, we want people to say 5, 75% of the time. Both telehealth at home and phone care achieved that goal on their very first survey and have maintained that throughout the summer. At the end of August, we'll have about 70,000 of these visits completed system-wide. Next slide, please. One of the things that I spend a lot of time on is the patient comments that come back on our surveys. The feedback we get from our patients is important. They're taking the time to provide that feedback. We want to read it and understand where there are consistencies with problems or other issues that we can resolve. And we received a lot of really positive feedback. Some of the feedback is mentioned or listed on the screen. One person said that if it's possible to have future appointments via telehealth, they'll always pick that over going to the office. The middle one is the one that really rings loudest for me. For us, it saved us driving 50 plus miles and saves money and time. And as employers, that's an important aspect, because if employees are coming to the Marshfield Clinic for care, they're leaving work. And I think we all know that if you leave work to go to urgent care, you're probably not going to be back in an hour. You're going to be gone for more than that, maybe the rest of the day. And so telehealth has the ability to keep employees more productive, keeping them at work for their doctor's visits that can be done remotely. And this is true for everybody, not just employees. It may be a senior who relies on an adult child to take a day off from work to drive them to Marshall for their appointment. It may be a mom or dad who has to haul 2 or 3 other kids along with them to the doctor's appointment for their child. Anytime we can use virtual visits or phone care visits to connect with those patients, we save them real time and money. It's not just the cost of your doctor's visit that's a cost for healthcare. It's the gas you spend driving here, the time you miss from work, et cetera. Next slide, please. Now, we want to be completely transparent, and we get negative comments too, and we want to understand what patients aren't liking about the service. We went through, I think there were about 180 negative comments, and I went through and read every one of them. About 82% had something to do with bandwidth or internet service. And there's an example of those on the screens. Problems getting connected, the web was bad audio experience, the connection was choppy, et cetera. Some patients absolutely like the experience of coming in and seeing their doctor in person. That's perfectly fine. But by and large, patients really like telehealth at home, but we did confirm something we've long known, and that is internet access for our patients is a significant barrier to delivering care into their home. Next slide, please. So as I mentioned, on August 3rd, President Trump did issue an executive order. That executive order by itself doesn't do much, but the executive order does direct Congress to make the reimbursement flexibilities that came along with COVID response permanent. That means telehealth and phone care need to be a reimbursable modality of care moving forward. For the duration of the public health emergency, will be under the flexibilities provided by the CARES Act. We anticipate that legislation will be introduced in Washington sometime during the lame duck period after the election that would change the rules for Medicare to make these reimbursement modalities permanent. We're actively working to expand what we can do in a telehealth home and encounter. Certainly, I think for the average person, you can think that a phone call versus a video visit is very different. You can do more in a video visit because you can see the patient, you can look at a rash, you can see their eyes, you can see their body language, much more so than you can on a phone. But you still can't listen to their heart and lungs, you still can't look in their ears, eyes, nose, and throat. And Marshfield Clinic has been working with a number of vendors who have technology to overcome that for a few years. In fact, some of you may have an e-clinic at your business site that uses a device called the TitleCare device to collect this information. We're certainly, especially with better reimbursement, going to be moving very quickly and seeing massive innovation in this space to increase the number of visits that can be done via telehealth at home. But that doesn't overcome the one sort of big elephant in the room, and that is we live in a very rural area that is very underserved by broadband. Over the last 5 years that I've been here with Marshfield Clinic, I've spent time in communities working with community leaders to help them understand what healthcare can be delivered into the home and encouraging them to apply for broadband expansion grants. In fact, Marshfield Clinic has been a contributor to many of those efforts by contributing some financially to broadband expansion projects in individual communities. That's going to take a long time to get everybody access to broadband if we can accomplish one small community per year. So recently, Governor Tony Evers announced the creation of the Broadband Task Force. This task force has been charged with evaluating broadband services across Wisconsin and coming up with an implementation plan for how we're going to get internet access to every resident of the state of Wisconsin. I came into this webinar just a few minutes late. I think I made it on time, but I was close because we had our first meeting of that today. And Marshfield Clinic does have a representative on that committee, and I'm honored to be in that capacity. We need to fix the rural broadband issue if we're going to see the growth of telehealth that we expect. I think all of us have lots of experience working with digital technology. We consume our entertainment digitally, we do our banking digitally, we do everything digitally except for healthcare. And that's going to change here over the next several years with these changes in reimbursement rules. But to fully take advantage of that, we need to see better broadband expansion across the state. And with that, I can wrap up and hand it back to Dr. Krieger and take any questions.
Thanks, Chris. Chris, did we get any questions in from the audience? I know we're about at time.
Yeah, we are actually at about a time, but we do have just a couple of questions that we wanted to ask. One for each of you, actually. And I'm going to start, Chris, with you. So you talked early on in your presentation about having to put other projects on hold, and then at the end you talked a little bit more about Care My Way at Work and the Title device. So talk a little bit more about, I know we had to put some of those on hold. We've got several employers out there that have already deployed their Title devices in their workplaces, and we've got a whole bunch more that have indicated that they're ready. So your team is now ready to make that rock and roll for them again. We're ready to restart that. Is that correct?
So we have restarted it. We're deploying another one this coming weekend. For those of you who aren't familiar, an e-clinic is simply a device. It's an iPad in a point of sale style case that has with it the Title device I mentioned earlier, that when put on site in an employer site allows employees to consume healthcare digitally on site without the need to come into Marshfield Clinic. The Title device allows us to do a little bit more than we can on a regular Care My Way visit, because now we have the ability to listen to your heart and lungs, or look in your ears, eyes, nose, or throat. The same team that ramped up and provided for our COVID response, the telehealth team, is responsible for deploying those units. So over the summer here, we've been diverted since March on getting those deployed. Looking forward, we do anticipate probably another round of COVID work that we're going to have to do this fall, and we're prepared for that if that call comes. But we also are working to get some of those e-clinics deployed. Obviously, it's a lot different post-COVID than it was pre-COVID. We're trying to figure out how you socially distance while you're trying to show somebody how to stick something in their ear, but we're working on processes to do that, provide more virtual education to the employees on how to use the device. Assuming that our fall isn't too crazy with COVID, I would expect that we would see most of those units getting deployed later this year, but of course that's a big question.
Yeah, and I got to say the feedback we've had from our employers that have been using their devices has been extraordinarily positive, and so we definitely wanted to promote this service. And again, with Security Health Plan, with most of the plans that you would have with us, those visits would be free to the members. So a really economical way of using their time, and really does promote presenteeism and reduces that absenteeism. So love the technology and love that we can use it and continue to deploy it. Corey, there was one question that came in regarding the ICS and implementing an ICS. So if an employer out there, even if they're maybe a relatively small employer, would you suggest that they have an ICS strategy? And if so, would you have any recommendations on how they might go about building one?
Yeah, that's a great question. I think there was value in it, not from the standpoint of having to lock yourself into using the military or healthcare ICS that was utilized here, but you certainly could have a modified approach as well. I've been in contact with several of the school districts as the administrators are working to try to figure out how to get school back in session. So kind of a corollary in terms of, operationalizing a business, so to speak. And one of the key things that I tried to pass along to them is, with all of the political connotations and all of the different issues that surround it from a social perspective, whatever your decision is as you're operating your business, whether it be a school or whether it be a manufacturing business or whatever, is contingency planning. And so how, do I have the resources I need to accomplish what I need to do today? How about what does the next 3 months look like? And then that longer term plan and beyond. And then what could go wrong? What is the, failure effect and mode analysis, which is a tool, and FEMA that we'll utilize in healthcare sometimes to say, how many different ways could this go wrong or break? And what position might I be in? And how can I mitigate the chances that that happens? And if it does happen, how do I plan for it so that I can mitigate the impact at the time? And so I think just going through that and pulling in key stakeholders, your HR people, your financial people, your folks that might be handling your supply chain, to just do some scenario planning and really just think through that. And doing a tabletop exercise is not a bad idea, really just to say, let's take something and play this through and talk about how we would handle it. And those conversations can be very enlightening in terms of identifying areas that you might not be as prepared as you thought you were, or identifying strategies that you can put in your back pocket that will help you if and when the time comes that you would need to address the situation. So I would highly encourage, if you haven't done that, to take some time to sit down with those key people in your organizations, however big or small that you are. It doesn't change the process, it just changes the people around the table, so to speak, to do some of that scenario planning, because that's really what it's all about, is identifying what the needs are today and how are we meeting them, and what does tomorrow look like and how do we plan for that.
Right, great responses. Gentlemen, thank you both for your time today. Oh, Chris, did you have something else you wanted to?
I just wanted to follow up on what Corey just said there from the standpoint of somebody who worked in the ICS structure under a chief like Corey. For me, it was all about removing the bureaucracy that is a necessary evil in almost all of our worlds. We have to have controls in place, lots of eyes looking at things in order to make approval for financial purchases or capital improvements. And the ICS structure, for me, removed a lot of those barriers. Of course, they're necessary. I'm not saying they're unnecessary, but in an emergency situation, being able to get decisions made quickly and making sure the information is getting to those who need to make those decisions is really imperative. And that's really what the ICS structure did. It really flattened our hierarchy and our organization. And I'll end with this. Normally, if we're looking for capital, there's a long review process that we go through. It may take 6 or 8 weeks to get approval to spend $50,000 on a project, and it should be evaluated from every angle. But if we know we need some equipment in order to meet the needs that we have right now, and we're in an ICS structure responding to something like COVID, we need to be able to have somebody who can make the decision to expend those funds and let us move forward. During our COVID response, we had a need like that. And I had emailed Dr. Krieger at about 6:30 or 7 o'clock at night, and by 5:30 the next morning, we had approval. That's what the ICS structure did for Marshfield Clinic. It made us able to respond much more quickly to the needs as they were being presented to us.
Great story, great ad. Thank you very much for chiming in on there, Chris. I'm sorry I was talking over you there. But gentlemen, again, thank you very much for your time today, and thanks for all the information. And again, to our guests, this will be sent to you via email. You can also find it on the Security Health Plan webpage under our COVID page. So please look it up there and share it with anybody you want. And again, gentlemen, thank you and have a great day, everybody. Be well.
Thank you.